For our next session, I would like to call upon Dr. Amit Kavimandan, sir. Sir is a senior gastroenterologist from Amravati. He will be presenting on management of pain in chronic pancreatitis. To chair this session, I would like to call upon Dr. Tanuja Manohar, Dr. Abhijit Deshmukh, Dr. Mahesh Shah, and Dr. Megha Balanki. I request all the chairpersons to kindly occupy their seats on the stage.
So after listening to a very informative lecture of acute pancreatitis, now patient has developed chronic pancreatitis. And most important symptom related to chronic pancreatitis is the pain, which has a tremendous effect on the quality of life of patient. I request Dr. Amit Kavimandan to say a few words about management of pain in chronic pancreatitis.
Okay, thank you, ma'am. So, good afternoon, everybody. First of all, I'd like to thank Dr. Mukhiyar sir, Team Midas, and API Vidarbha chapter for giving this opportunity and organizing such a wonderful conference. And it's a packed house, even in post-lunch session. So, it's a tribute to the organizers. So, yes, we are going to talk about management of pain in chronic pancreatitis. Bhushan spoke very passionately about acute pancreatitis. I'm going to talk about chronic pancreatitis. As we know, etiology of chronic pancreatitis in India most commonly is idiopathic, second is alcohol, and other etiologies are also there. And as madam said, the most common clinical feature is pain. The pain is what the patient brings, the patient comes to you with. He has chronic pancreatitis, he will have severe unrelenting pain, and it is also the most common indication for intervention in chronic pancreatitis also. And it has a significant negative impact on quality of life of the patient. Patient has persistent pain, he is taking analgesics, he is going to one doctor to second doctor, and is suffering. So it is very difficult to manage, and the etiology of pain which has been thought of is chronic or recurrent inflammation into the pancreas. Because of the etiology, either the patient is not stopping alcohol, or the primary etiology has not been worked up and it has not been managed well, or the patient has developed local complications like a pseudocyst or a biliary obstruction or a gastric outlet obstruction. And one of the mechanism is also a neurogenic mechanism. These patients develop a neuropathy kind of pain where they become more pain sensitive, so that threshold for pain becomes lower. So before we start the treatment, we must have an assessment of the pain. A detailed history must be taken. What is the etiology? If the etiology is alcohol, alcohol has to be stopped. Smoking has to be stopped. Tobacco has to be stopped. Otherwise, his pain is not going to go away. Then the character of the pain has to be assessed, whether it is constant, intermittent, whether the specific triggers are there, then the trigger points have to be avoided. Severity, and what is the impact on quality of life. And as I said, we have to rule out other causes of pain which can be associated with chronic pancreatitis. Patients with chronic pancreatitis are prone to develop peptic ulcer disease. So do a just diagnostic upper GI endoscopy, rule out peptic ulcer disease. Patients who are having severe persistent pain, please rule out a pancreatic carcinoma. Patients who have idiopathic chronic pancreatitis are prone to develop pancreatic malignancies. And if the pancreatic malignancy is not detected and you are just treating it like as chronic pancreatitis, patient may land up in metastatic disease. Patients may sometimes develop gastroparesis. Patients who are using opioids for pain may develop narcotic bowel. So they may have pain because of that, and they may have local complications like pancreatic pseudocyst, duodenal or biliary obstruction. Next thing is that we have taken a history, then we should image the pancreas to see what is the morphology of the pancreas. We can do an CT scan, an MRCP or an endoscopic ultrasound. All of them give good images of the pancreas. And why it is important to do an imaging while managing pain? Because we want to assess the anatomy and the diameter of pancreatic duct, because that is going to give us an idea what therapy we are going to give it to the patient. So the therapy for management of pain in chronic pancreatitis is different in patients who are having dilated pancreatic ducts and patients who are having non-dilated pancreatic duct. So it is very important to have the imaging. The first thing when the patient comes to you is obviously you're going to give him analgesics. The analgesic we can use is a paracetamol. Please avoid NSAIDs because of the all GI toxicity they will cause. The next step is opioids. Tramadol is a widely used opioid and it has good effect in patients with chronic pancreatitis. Along with analgesics, we can use adjunctive drugs like tricyclic antidepressants, that is like amitriptyline. SSRIs can also be used like duloxetine. Then gabapentin and pregabalin, they have been shown to have good effect because as we discussed earlier, one of the mechanism of pain in chronic pancreatitis is neuropathic pain. So these drugs do add an effect and sometimes they have shown to decrease the pain significantly. The next comes is in the drugs is antioxidants. Very commonly used for chronic pancreatitis, antioxidants are used. The mechanism of use of antioxidant is that there is oxidative stress in the etiology of chronic pancreatitis, particularly idiopathic pancreatitis. So it is more important in idiopathic pancreatitis. The studies, multiple studies have been done, randomized controlled trials have been done in India also. The meta-analysis of these trials have shown that they reduce the pain, but the effect size is small. So only few patients will improve with antioxidants, and around 10 to 15% patients will have side effects with antioxidants also, although they are minor. And the most commonly used combination which is studied should contain vitamin E, vitamin C, beta carotene, selenium and methionine. Out of these, selenium and methionine are the most important components of any antioxidant. So if you are using any antioxidant, please ensure that these two things are there. Its effect also depends upon the patient's nutritional status. If the patient is nutritionally deficient, which usually happens in India, patients with idiopathic pancreatitis, even with alcoholic pancreatitis, they are deficient, they are more likely to benefit from antioxidant therapy. And combination of antioxidants and pregabalin can also be used in patients who have undergone either surgery or endoscopic therapy and they have a recurrence of pain. So antioxidants can be used. So antioxidants are useful, but the effect is small. Then we come to pancreatic enzyme supplements. So whenever somebody says chronic pancreatitis, first thing comes to our mind is pancreatic enzyme supplements. So everybody prescribes pancreatic enzyme supplements. But are they useful for management of pain in chronic pancreatitis? That is the question. Usually what they've been prescribed is for management of exocrine insufficiency, that is management of malabsorption, that is steatorrhea. But for pain, the rationale is that when we give pancreatic enzymes, they decrease the cholecystokinin in the duodenum and decrease the pancreatic stimulation. For that, they require a higher dose of protease enzymes. Lipase is not required for pain control. Lipase is required for exocrine insufficiency. Protease is required for pain control. An important thing is that for pain control, we need to use non-enteric coated pancreatic enzymes, because enteric coated pancreatic enzyme will be released in distal intestine like jejunum, and the effect is required in duodenum for pain control. And few studies have shown benefit, but meta-analysis has shown no benefit with pancreatic enzyme supplementation in pain management. So, but it is still widely used. So now we coming to, so we've tried analgesics, we've given antioxidants, we've given pancreatic enzyme supplements, but the patient has persistent pain. So now comes the role of intervention. Now we want to intervene. So there are two options. We can do an endoscopic therapy or a surgery. So the role depends upon how is his pancreatic duct. So if the patient has a dilated pancreatic duct, lies like in this MRCP, we can see the MPD is dilated, it has stone, there are some strictures also. So these patients are likely to benefit from endoscopic therapy. So what is the role of endoscopic therapy is to improve flow through the pancreatic duct by removing stones or by treating the strictures. Again here careful patient selection is essential. As I said, we need to have an imaging. The pancreatic duct should be dilated, there should be stones or strictures. So the endoscopic therapy we do is endoscopic retrograde cholangiopancreatography, that is ERCP, and we try to remove the stones. But like in CBD stone, not every pancreatic stone needs to be removed, and not every pancreatic stone will cause pain also. Sometimes if you do an MRCP, the patient Patient may have incidental chronic pancreatitis, he may have a very large MPD like 6 mm, 7 mm MPD, there will be multiple stones, but patient may hardly have any pain. So that the stone need not be removed. Sometimes patients may have large stones, large MPD, and they will just respond to your antioxidant therapy. So it is not that you should always treat the images. But if the patient is not responding to conservative management, has dilated duct with stones, then you should do an ERCP. And if the stones are less than 5 mm in size, we can safely do an ERCP, remove the stones and put in the stent. Again, complete clearance of pancreatic duct is not required. Even if you are able to clear around 60-70% of the stones, that is good enough. But if the patient has large stone, that is more than 5 mm of stone, these stones you are not going to be tackled by just ERCP only. You are going to require something which the urologist been using for so long, that is ESW, that is extracorporeal shockwave lithotripsy. So what is that? Is basically primarily used for renal stones, uses the principle of shockwave energy. It has a shockwave generator which is now electromagnetic. It has a focusing system, and we can localize the stones in the pancreatic duct. If the stones are radio opaque, we can see by fluoroscopy. If they are radiolucent, we can see them by ultrasound. And we give shocks to those directed shocks. They will require multiple sessions, like 2 or 3 sessions, till the stones gets pulverized and the stone size becomes less than 3 mm. Once the stones become small, then we can remove the stones by ERCP. And this is the principle of ERCP, and ESWL has actually revolutionized the management of chronic pancreatitis. This is a ESWL photo from Midas only. It has been shown that patients who undergo chronic pancreatitis and large stool, if they have undergone ESWL, they will sometimes the patients will have pain relief even without ERCP also. So ERCP clearance may not be required. And patient has stricture, we can put in a plastic stent which can keep for 1 year. We can have the stent exchanges every 3 months or 6 months. Or patients has the stricture cannot go down, we can put in multiple plastic stents. So endoscopic therapy when combined with ESWL has good results. If you can see in this image, there is a large stone in the pancreatic duct. Post shockwave lithotripsy, the stone is all fragmented. We can remove the stone fragments and put in a stent. And these patients have good response. Again, patient selection is important. Anatomy is important. Patients having stones in the body and head, proximal body and head, will respond to this kind of therapy. Patients having diffuse disease in the distal, like tail of pancreas, will not respond to this. And 80% patients will have pain relief at 6 months. But as again, endoscopic therapy will be less effective in patients who are having distal body and tail strictures or stones and multiple strictures like these. If patient has multiple strictures like this, endoscopy therapy will not work much. So now comes the role of surgery. So when do we offer surgery to patients with chronic pancreatitis? Chronic pancreatitis is obviously a chronic disease. Patients who have undergone endoscopic therapy may require multiple sessions. It is not that you do one endoscopic therapy and patients will respond. Some patients require 2, 3, 4, 5 sessions also. So some patients fail endoscopic therapies. If you have done almost 4 to 5 sessions and after that the patient is not responding, we should consider surgery. Patients whose anatomy is not amenable to endoscopic therapy, like patients having diffuse disease, multiple strictures, then distal body strictures or stones, surgery should be avoided, and patients having severe pain despite endoscopic therapy. So what are the types of surgeries? Types of surgeries are decompression. Basically, again, we have to drain the pancreatic duct. Pancreatic duct is obstructed, there is high pressure in the duct, there are stones. So we have to decompress the pancreatic duct, decrease the pancreatic ductal pressure. Or patients have inflammatory mass, there are large stones in the head. Such patients should undergo resection surgery along with combined decompression surgery. So we can have combined surgeries also. So these are different kinds of pancreatic surgeries available in chronic pancreatitis. Earlier used to be like standard Whipple surgery, in which the head of the pancreas used to be removed, but that would cause loss of endocrine and exocrine function. So now head preserving surgeries are being done, in which there is lateral pancreaticojejunostomy, when you open the pancreatic duct and anastomose jejunum with the pancreas, so that decompression of the pancreatic duct is also there. Pancreatic parenchyma, exocrine function, endocrine functions are being preserved. And there are multiple variations of this surgery. So this surgery for chronic pancreatitis gives pain relief almost 75 to 80% at 2 years, and pain relief in surgery is durable. So as we see, patients who are not responding to conservative management, endoscopic therapy in selected patients where there is anatomy is amenable, they have good results. Patients who are not responding to endoscopic therapy, surgery has durable results, long-term results, 70 to 80% at 2 years, and even at 5 years, 60% patients are there. But the important point to note that there are some patients who will not respond to surgery also. So there are such kind of unfortunate patients also. And there are patients who are having chronic pancreatitis duct, but the pancreatic duct is not dilated. So what are the options in those patients? We have very few options in that. As we discussed, this is the pathology behind chronic pancreatitis. One of these neuropathic pain. So what we can do is a celiac plexus block can be done in such patients. It can be relieved in refractory patients. Patients will receive either bupivacaine with steroids. It could be a CT guided or EUS guided celiac plexus block. But again, this is temporary. This lasts for 3 to 6 months, and it is difficult to predict which patients will respond. And those patients who are not responding to celiac plexus block, surgical resection can be tried. That is head dominant, we can do a Whipple's, remove the head. If tail dominant is there, we can do a distal pancreatectomy. And if diffuse is a very radical surgery of total pancreatectomy can be done with islet cell autotransplantation, but this has lot of complications. So to summarize, patients who are having typical history of chronic pancreatitis, imaging is there. Patient is a candidate for endoscopic therapy. Endoscopic therapy would be the first choice combined with extracorporeal shockwave lithotripsy. Patients who are not good candidates for endoscopy or failed endoscopy, then we can consider them for head preserving pancreatic surgeries. So I thank you.
Excellent lecture, Amit. As usual, a difficult topic covered so well. What's your opinion on role of pancreatoscopy and use of various lasers and basically use of ESWL through pancreatoscopy?
Okay.
And second question is, when you treat chronic pancreatitis, if the patient is having pain, say once in a year, which is mild, but has significant diabetes and exocrine and endocrine insufficiency. So do interventions help in these patients from this aspect also, like treating their insufficiencies? And
okay, very good question. So yes, pancreatoscopy, like with spyglass coming up and cholangioscopy coming up, pancreatic scopy is also come up, and people have been using lasers inside the pancreatic duct also, and they have been useful also, and with the improvement in technology, so that is also one of the promising era where we can use that in chronic pancreatitis. And as you asked about the exocrine and endocrine preservation, yes, the endoscopic therapies do help in preservation of these exocrine functions somewhat, but not entirely. And as we said, endocrine dysfunction is not much of a problem in chronic pancreatitis. So as we suspect that many patients will develop diabetes, but natural history studies have shown that the incidence of diabetes is not very high, to the tune of 40–50% only.
I would just like to make a comment. Thank you. It was a very nice talk.
Thank you.
So regarding pancreatoscopy, I think there's some now evidence that has now come about because it's a new technique. If you achieve ductal clearance, then you can get similar results like ESWL, but in a select group of patients, which is limited stone burden, no strictures, less than 3 stones, only in the head neck region. In those cases, we can consider it as an alternative. So yeah.
So again, I think patient selection, case
Patient
selection
is
is very, very important.
Yeah.
And not all pancreatic stones need to be removed. That is the message.
That's true. No, I think majority are asymptomatic. So they don't need to do anything. That's true. That's true.
Not all need to be removed and not all will become better.
Yeah, so, and there is recurrence also. So if you remove it, they will develop stones again.
I think only last week, because I was doing a similar presentation, there was some new data to say that it may alter early ESWL in the course, may actually alter the natural history.
Natural history, yes.
That I think if you've come across also. I mean, it's less data, but it's saying that it may improve your overall sort of exocrine, endocrine insufficiency if you treat stones early.
Maybe
There is one or two studies
First 3 years
of the disease or diagnosis
yeah,
there. That's true.
In India, most of the patients are idiopathic, and they start early in their age.
True.
So probably if we treat them aggressively early, the course may change.
Change the natural course if they're at the age of 10 and 12, we treat them, I think,
Very nicely said, Amit sir. So only one thing is that I think we should, from chronic pancreatitis and pancreatic duct clearance is a very important concept. Putting stent just into pancreatic duct is just giving a pain relief, will not solution for the patient. Yes, now time since we are in hospital from last 8 months, we are doing ESWL. We are doing such a good result. Slowly in coming meet, I will going to discuss about the results of ESWL in our, which was done. Stones which are really larger enough, which was just putting a stone, even the stent was not allowing. Doing ESWL, we are able to not only clear a duct and also put a stent, and also some patients I am putting a stent-free trial. So yes, ESWL is a game changer in management of a patient having a dilated duct and a limited stone burden, at least in the head. Not like in everything is ESWL, but yes, if a patient having a burden of a stone, especially in the head and genu, we can definitely achieve a duct clearance and can give a result which is as best as surgery. That is shown in the JAMA study. If you achieve a duct clearance, problem with our endoscopic technique is because of that we are not able to give a duct clearance. We just pain relief, just like a paracetamol giving a pain relief for fever, the fever down. That's the only thing, but solution. Thank you.
Sometimes after ESWL, ERCP may not be required also.
Yeah, sir. We are giving such thing. Yes, sir. Thank you, sir.
One question, please. You said there is no need to clear all the pancreatic stones. Why it is so? These stones can increase in size and can cause problem in due course of time.
The problem is that the pancreatic stones are not the cause. Pancreatic stones are the effect of the chronic pancreatitis.
Will they cause stricture?
They are not causing the strictures. They are the effect of inflammation. So like in CBD stone, if we see a CBD stone, the jaundice is caused by the CBD stone. Here the chronic pancreatitis is causing the stones rather than stones causing the chronic pancreatitis. So you should not chase the stone.
End of the day, ma'am, it is just like an impacted stone. It is not a pancreatic juice not flow into duodenum. That may cause that is a theory of some thing. If it is causing intraductal hypertension, that is required for removing. Not as you say, like sir is right. Not every stone need to be removed. If the stone is causing pain and causing decreased flow and dilated, yes, we need to remove that stone. That is the remove every. Yeah.
So thank you. It was very nice and informative lecture. So every aspect of pain because of chronic pancreatitis you have explained very well. So thank you very much.
Thank you, sir. Thank you for an insightful session. Thank you to the chairpersons. I would please request you to collect your mementos.